In this module, we're going to be talking about clinical and counseling assessments. So again, in the broader pattern of psychological tests and measurements. And again, the idea that with psychology, we're wanting to measure individual differences and thoughts, cognitions, behaviors, and also feelings and attitudes, affect. So that when we're talking about psychology, we're talking about how do we actually are wanting to measure people's personalities, their attitudes, their opinions. We want to measure their behaviors, and we also want to measure and quantify their thought processes and their cognitions. And a part of psychological tests and measures is coming up with a quantitative way, a numerical way to measure and differentiate people. So with clinical and counseling assessment, again, we're doing that same process. We're trying to quantify constructs, and we're trying to quantify those constructs to be able to differentiate or individualize people, make differences, or basically be able to determine differences in this case, generally functioning from one individual to another. So we're going to be talking about clinical and counseling assessments in this module, primarily kind of the constraints that the process of making an assessment looking at clinical issues, so psychological health and psychological well-being, but also psychological and real-world functioning. And most of our models are based on a medical model where we're actually looking for a diagnosis. And that's also somewhat guided the measures that we're going to be talking about when we're trying to make clinical and counseling assessments. So I guess the first thing we should do is distinguish broadly between clinical and counseling assessments. And there is a fair amount of overlap between clinical psychology and counseling psychology. But what differentiates the two typically is that clinical psychology has a primary focus on prevention, diagnosis, and treatment of abnormal behavior, with a focus on the more severe forms of psychopathology. So clinical psychology is following closer to the medical model. It is more focused on identifying abnormal behaviors, and more specifically, generally, difficulty in life function. So when someone is actually having mental issues, psychological issues that are impacting their ability to live their lives successfully, and also to interact with the culture and society that they belong. And that's kind of an important factor too, is that whenever we're talking about quantifying what is normal behavior and what is abnormal behavior, what behaviors a society accepts and what behaviors a society finds to be abnormal or a problem, can vary from culture to culture. So, for example, even dress style. In some societies, different dress styles are indicating whether that's a normal or abnormal behavior. So, anyway, and then we have counseling psychology, a branch of psychology that expresses similar concerns and often has very similar training modules. But instead of the focus being on identifying abnormal behavior or severe psychopathology, it's more focused on helping people that are quote unquote within the range of normal behavior, but are still finding that same issue of having issues with basically everyday life. So having difficulty coping, having difficulty basically having the life satisfaction that they're wanting out of their lives. So much more everyday concerns, marriage, family, academics, and career. So various questions addressed throughout the use of an assessment tool in clinical and counseling psychology include. So basically when we're talking about psychological assessment from a clinical or counseling framework, one of the questions often asked, especially from a clinical psychology, is does this patient have a diagnosable mental disorder? In other words, do they qualify? Do their behaviors, their affect, their attitudes, and their cognitions, their thoughts, follow a pattern that would actually indicate through symptoms that they actually qualify or count as having a mental disorder? And again, that's a quantification process. That's a measurement. That's assessment. The clinician would be going through a series of checklists and or measures to determine, does this person actually count as having a mental disorder? So it's focused on what is the diagnosis. So is there a medical diagnosis of a mental disorder? Now, both a clinical and counseling psychologist would be very interested, regardless of whether they're actually trying to quantify whether someone has a diagnosable mental disorder, is also just what the person's current level of functioning is. So, how much is their psychological function positively or negatively impacting their day-to-day life? How well are they their behaviors, their thoughts, and their feelings, allowing them to integrate with the culture that they exist within. So how does that current level of function then compare with the others in their cohort? So basically, again, a comparative function. So we're looking at the range of normal cognitions, the range of what a society considers are normal feelings and behaviors, and the range of, what's the normal set of behaviors. So various behaviors and thoughts change culturally. So if you were what is considered to be almost completely unacceptable racist thoughts today, 50 years ago would have almost been considered the norm, and if you didn't hold those thoughts, you would be actually one of the outliers. So things, again, it's very important to recognize that when we're talking about the diagnosis or measurement of psychological function, that it really is a quote-unquote function of not only what are the behaviors, the thoughts, and the feelings of the person, but how well does that match to the current society, current culture's norms. The more you're within the norms of behavior and thoughts and feelings within a society, the more likely you are going to be functioning better. People are not going to be reacting negatively to you. Your behaviors will be seen as quote-unquote normal. And there's definitely some range for different behaviors, different thoughts, different attitudes. But at a certain level, if you get so far from that norm, people are going to start to not behave normally around you. They're going to treat you as different, and then that may itself cause problems. Now, some people may want to be that way and are comfortable. I'm a misfit, no one likes me, and that's fine. This is who I want to be. It's when someone is struggling with that, when someone goes, I don't want to be an outcast, I don't want to be behaving these ways that the rest of society doesn't agree with, that's when it becomes a problem for that person, and that's when psychologists should be stepping in to help that person at their own request. And if the behavior is actually diagnosable as a mental order, possibly stepping in through the orders of the medical establishment and also legal situations or legal requirements to actually help that individual. So once we actually know, is there a mental disorder? Is there a diagnosis? What's the current level of functioning? And how does that functioning compare to kind of societal norms? Then we can ask what type of treatment can benefit this individual, and also how well the person's personality can be described. So we're also just creating personality profiles. So sometimes it's not even necessarily that we would be doing a psychological assessment from a clinical and counseling viewpoint, specifically looking for treatment or function or diagnosis. Sometimes it might be just to tell someone, kind of again like with vocational psychology, here's kind of a overview of what your personality is like, your strengths and weaknesses. So from a clinical model, the diagnosis of mental disorders are the frequent assessment tools used to make these diagnoses. And primarily, though there are many different assessments and tools used to measure individual symptoms of mental disorders, due to the medical model of psychiatry, the medical model of clinical psychology, and also the insurance and legal requirements within the United States, primarily the main assessment tool used for the diagnosis of mental disorders is the American Psychiatric Association's Diagnostic Statistic Manual, the DSM. And this is our primary resource and reference source for diagnosis, and it's also our measurement. And most of these, the way it measures is for each diagnosis, for each mental psychopathology that has been identified, there is a checklist of basically thoughts, behaviors, and attitudes that the clinician would use to basically kind of do a checklist. And if enough of them are checked, it indicates that a diagnosis can be given, which also then means that that person might also be eligible for medical benefits depending on their insurance, and also possibly may even need to have treatment delivered against their will if it's actually of a criminal nature. Currently, we're on the DSM-4TR, and it names and describes all known mental disorders, including a category called conditions not attributable to a mental disorder that are the focus of attentions for treatment. And this basically is a catch-all category of it is clear that you're having a problem functioning in society. It is clear that you are in distress. However, you weren't necessarily diagnosable anywhere else under any of the other disorders that are currently being accepted. And the DSM has changed over the years, and again, that change is often based on what's acceptable in society. Many years ago, the DSM included homosexuality and lesbianism as a diagnosis. It was a disorder that should be treated. That, of course, is not the case today. And again, this kind of refers back to that cultural component of our diagnosis of mental disorders. There's a fair amount of controversy that surrounds the utility of the DSM. As I said, it's firmly rooted in the medical model and then discounts patterns of thinking and behavior, concepts arguably central to mental health. It's really focused on a checklist of symptoms. So it comes from a medical order. Does the person display this particular symptom? There's very few questions throughout the DSM about overt behavior, overall behavior, or cognition for the most part. It's more of, so for depression, for instance, does the person have problems sleeping? Does the person show despondency? So again, it's kind of this more, it often refers to general behaviors, but it's really not a model that's measuring the thinking and overall behaviors of the person. Different clinicians interviewing the same patients may very well produce different diagnoses based on their interpretations and the use of the DSM. So the DSM often is broad symptoms, and it's a yes or no pattern of checklist. So basically, there's 10 or 15 items for each diagnosis that someone has to go through, and they have to make a judgment call. Do I think the person is exhibiting this symptom to the level that I should check, yes, they're suffering from this particular result of their psychopathology? And in patients that may not be very severe, different clinicians may check yes or no depending on how they personally make the judgment of whether the person is actually suffering from that particular symptom. Also, an argument is made that DSM may be culturally insensitive and thus often is of limited use in diverse populations. So again, if our definition of what is normal behavior is based on culture, the DSM is pretty much normed, if you will, on a broad view of the entirety of the United States of America, and in fact an attempt to make it pretty much a world usable document, and the DSM is often used outside of the United States. But then what is acceptable behavior in culturally different populations, so diverse populations? And sometimes behaviors are different, and acceptable behaviors are different. What might be acceptable in one culture may be completely unacceptable in another. Some places and in some societies, having schizophrenia is often seen as a sign of a blessing, that person is considered to be basically a person to go to get extra information. They're actually applauded in those societies. So again, if we have this broad-based concept of trying to quantify whether someone or else has a mental disorder, and mental disorders have a component of, are you functioning within the norms of behavior? When we have a diagnostic tool that is meant to cover millions and millions of people, it may be fairly insensitive to specific diverse populations. So within the DSM, there is coded areas on 5 axes. So axis 1 is disorders of infancy, childhood, adolescence, dementias, substance use disorders, mood and anxiety disorders, schizophrenia, and also conditions that may focus on treatment but are not a cause for diagnosis. So that's our big broad category of a lot of where a lot of these psychopathologies we often think of are axis 1 psychopathologies. Axis 2 is mental retardation and personality disorders. And you can kind of start to see that this is, again, very much clumped, not necessarily on whether it's a psychological disorder or a physical disorder. It's more simply lumped on symptoms. So personality disorders, which are generally going to be a cognitive disorder, a framework disorder, how someone actually is viewing the world, and mental retardation, which is usually going to be a physical disorder, are all axis 2. Axis 3 is physical conditions that may affect mental functioning, so beyond mental retardation, if there's actually a hormonal imbalance, if there has been structural damage to the person that affects mental functioning, that would be an axis 3 disorder. Axis 4 is different problems of sources of stress, such as financial, legal, marital, occupational, and other problems. So most of the mental disorders in Axis 4 are often more counseling focused. So there are often people dealing with particular events, an enormous amount of stress, particular pressures that are causing them to have problems functioning in society. And then Axis 5 are global ratings of overall functionings. So since the diagnostic manual is primarily simply a checklist of symptoms, the clinical interview is one of the major assessment tools when using the DSM. And a clinical interview may be conducted for several reasons, often to arrive at a diagnosis. So basically interviewing the patient to ask them about their experiences, how they're functioning, but with a purpose of basically addressing each of the points of the diagnosis. It also can be used to pinpoint areas that must be addressed in psychotherapy. So finding out what is the person's problems, what are they struggling with, and that might also provide information on potential treatment. Clinical assessments often are legally required to also determine whether the individual will harm himself or others. So a clinician is actually under a legal obligation to make sure that someone is not going to be likely to self-harm or to harm others. And if they believe that they are, so the diagnosis is suggesting this person is in imminent danger of harming themselves or others, there is actually state and federal required reporting in those situations. And finally, to guide decisions about what else needs to be done to assess the individual. So often the clinical interview will be the first step, and then additional assessments, including more quantitative assessments such as a personality test, maybe a cognitive ability test, might also be ordered to further support the clinical assessment interviews diagnoses. The current trend in clinical and counseling assessment is towards culturally informed assessment. It is an approach to evaluation that is perceptive and responds to the issues of acculturation, values, identity, worldview, language, and other culture-related variables as they possibly impact and evaluate, process, and interpret the resulting data. So that's a pretty packed up sentence, but what this really means is trying to move ourselves to recognizing that there are gender differences, for example, in normal behavior. If we have a male that has a tendency, a man in our society, who has a tendency to cry in lots of situations, to become very emotionally upset in a lot of places, that's usually seen as not necessarily normal masculine behavior. Now, if the person that is doing this still finds it fine to function their life, they don't mind being emotional, they don't mind crying in public, then that's not necessarily a problem with that psychological assessment needs to identify. However, that is kind of out of the norm of masculine behavior, and if the person is also finding that behavior to cause them negative impact in their day-to-day life, that's going to be something that might be diagnosable. But that exact same behavior may not be seen as a problem in women. Now, again, it's up to the individual to determine, and a woman could definitely well be, I don't like being this emotional and I want help with it. But again, when we're looking at culturally informed psychological assessment, we want to start thinking about not just broad norms of behavior, but norms of behavior in different age categories, amongst different religions, amongst different ethnicities, again, amongst different sexual orientations, against different national origins. So basically, it's pretty easy to go online and go to any one of those top 10 weird lists that are all over the internet. So, and a lot of times they'll be talking about other countries that do quote unquote weird behaviors. So I just recently saw top 10, top 10 celebrations that will surprise you. And it was all about various things that different countries actually have holidays for that seem very strange for people that grew up in the United States. Of course, the holidays we have probably look strange to other cultures as well, and some of the ways we celebrate them. So just looking at the holiday season, our tendency to kill a tree to celebrate the winter season, and then to decorate it, and then afterwards to throw it away. Some societies would probably look at that as a pretty strange and wasteful behavior, but we think nothing of it. I have a live trail, not anymore, a slowly dying tree in my own house right now, festooned with Christmas lights and covered in various ornaments. And again, in the culture that I'm in, that is an acceptable behavior, but that might not necessarily be an acceptable behavior somewhere else. And trying to assess this and include this in our clinical and cultural assessments, in our counseling assessments, is an area that we're definitely seeing movement in, to understand that if we're really wanting to talk about psychopathology, clinical and counseling psychology with an air to not trying to come up with a broad medical diagnosis, but to simply ask the question, is the person's behavior negatively impacting the success and their satisfaction with life? And if so, then we need to take into account age, disability, religion, ethnicity, social status, sexual orientation, heritage, national origin, and gender when we're trying to assess what is normal behavior to find out if the person's functioning well. So some special applications of clinical measures. So one form is the forensic psychological assessment. So the theory and application of psychological education and measurement in legal context. And like I said, there is some legal impact and also private industry impact on clinical and counseling assessment. So from a private industry viewpoint, the insurance industry and the medical model has definitely had an impact on how we measure psychopathology. But also the legal system of the United States. So forensics refers to legal psychological assessment. So, three core findings in our legal system that have impacted clinical measurement. The first one is Tarasoff and the Regents of the University of California. And that ruling, so basically, the way laws are created in this country can come from three sources. They can come from the executive branch through executive orders that basically say, based on a presidential order, there is an expectation of legal behavior within the country. Most laws are actually passed through our actual elected officials, so through the House of Representatives and the Senate, total Congress. And once those laws are passed, though, it is up to the courts to determine how they should actually be interpreted. So these are all court interpretation cases. But once they've been determined, they're considered case law. So basically, there was an ambiguity in the law, and in the case of Tarasoff versus the Regents of University of California, the court system ruled this is what the law is meant to say. And what this law says is this is kind of the law that all of the concepts of mandatory reporting are based on. If someone is under psychological assessment and it's clear they're dangerous to oneself or others, it is the responsibility of the clinician to inform the authorities that this person may need to be detained. Dusky versus the United States actually establishes that forensic psychological assessment can be used to determine if someone is competent to stand trial. This isn't necessarily determining, quote unquote, an insanity defense. This is simply asking, is the person aware of the process that's going on? Are they aware and cognitive of the fact that they're under trial? So again, this can occasionally come up where someone is found to not be competent to stand trial and are actually remanded to psychological treatment over legal treatment. Now, often, depending on the state, once they're found competent, they may still be accountable for whatever they were going to be tried for. And then finally, criminal responsibility. Were they capable of knowing that they had made a criminal act? And that's Dunham versus the United States. There's many other laws and court precedences that also affect forensic psychology and the psychological assessment of mental disorder or psychopathology. These are the three big ones, though. Additional psychological assessments from a forensic standpoint include determination of the readiness for parole or probation. Usually a forensic psychologist will do a psychological assessment of someone that is hoping to get out of jail early or to get probation. Diagnosis and evaluation of emotional injury. So often also the victims of various crimes will be suffering from kind of state-based stress and psychological issues, and the forensic psychology will often be involved in the treatment of that. And also profiling, so creating patterns of personality profiles and to try to determine the potential behavior of people that are still committing crimes. So the FBI is probably the most well-known use of forensic psychologists in the job of creating profiles of basically criminals that they are still in the process of trying to catch. Additional special applications of clinical measures within the legal system include custody evaluations, so psychological assessments of parents and guardians, their parental capacity, and also of the children and the parental needs and preferences. So this involves evaluations of parents, evaluations of child, trying to make decisions of what is best for the parents and the child in custody battles. Also, clinical assessment can be used to determine the impact and effects of child abuse and neglect, including both the physical signs but also the emotional and behavioral signs of that abuse and neglect. So when we're looking at a psychological report, generally speaking, the end result of any type of clinical or counseling assessment is going to be an actual written report, either stating why the diagnosis was given or why a particular treatment is being used, or just simply the personality profile that has been generated to be then discussed with the person. There's a couple of things to notice, though, that psychological reports vary depending on their purpose. The first thing we know is what's called the Barnum effect, and this is that generally speaking, people tend to accept vague personality descriptions as accurate descriptions of themselves. So generally speaking, if you're simply trying to validate a clinical report by going, well, do you agree with the report? Unless the report is incredibly specific, we generally, when people start talking about what a test says our personality is like, our tendency is, even if it isn't necessarily a great description of us, we can easily start looking for, well, I wouldn't say I'm that conscientious, but now that you mention it, I do like to clean up occasionally. So we tend to actually view such information with kind of a confirmation bias. So when someone tells you that you're really smart. You'll often try to think of times, well, maybe I am. Maybe there is examples in my life that I'm really smart. Clinical prediction. The application of clinicians' own training and clinical experience is a determining factor in clinical judgments and actions. So a lot of research has actually found that the clinician themselves, their own experiences, the types of patients they've had, and their own training is also just a predictive aspect of the kinds of diagnosis they give. And this again gets to that idea that two different clinicians using the same checklist might come up with different diagnoses. So let's think about that for a second. What this means is that if the process of making a psychological determination of psychopathology is comparing the person that you're interviewing to a normed group, most times the clinical psychologist is the one that is making a judgment call of, is this normal behavior? So if we have two clinical psychologists that are interviewing someone that is basically suffering from depression by their own words, they claim they're depressed and they're coming in hoping that they can get a diagnosis. If one of the clinicians primarily doesn't work with depression, primarily works with people that are basically having, for example, marital and family disputes, as the person starts to describe their moderate depression symptoms, that person might go, wow, you sound really depressed. I've had hundreds of patients in here, and you're probably one of the most depressed people I've ever met. So they're very likely then to check yes, 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 down that checklist for depression. That same person goes into a clinical psychologist who mainly works with people that have depression. So he has seen, or she, an enormous number of people that suffer from depression and recognize that this person is somewhere in the middle. They may actually not check many of those boxes at all in the DSM, as they're comparing them to people that are suffering from severe depression. So this is a problem with the psychological report. Just like the Barnum effect, we have a tendency when we hear a psychological report to kind of look for evidence that suggests that yes, that report does fit us. We also know that the actual data that we get out, the diagnosis we get out, is somewhat dependent on the person giving the assessment. Mechanical prediction, however, so if we're using clinical prediction, it means that we're allowing that judgment to still be in the hands of the clinician themselves. They get to decide whether or not the person has diagnosis. They get to decide whether or not to use a particular treatment. There has been a fair amount of research that says if we use mechanical prediction, so in other words, if we simply use the assessments we use, such as personality tests, cognitive ability tests, and even the DSM once it's checked off, to then enter into a statistical rules of probability, so a computer-generated finding and recommendations. So we let an actual computer crunch the numbers and come up with a diagnosis. That those diagnoses are not necessarily 100% more accurate, but they're more likely to be consistent. And again, there is, of course, resistance to this idea of letting computers diagnose us for mental disorder. But it is something that, again, we're seeing some movement towards in the research.